Several years ago, Dr. Taylor and some other colleagues, including physicians here in Ontario, we measured the intended patterns of practice for physicians looking after patients with acute heart attacks. And ASA is aspirin, thrombolytic therapy, BB is beta blocker. Those first three bars are all proven therapies for acute heart attack. And these doctors, of which there are several thousand, GPs, emergency room physicians, internists, cardiologists, you see the care gap by intention is extremely small. They intend to give nearly 100% aspirin, thrombolytic, and beta blockers, the proven therapies of the day. Here's a reflection of the measured care at the same time. Some of the same physicians are in this, same provinces. It's, again, a very large sample. First time I measured a pattern of practice, it was around heart attack, and we had 207 total patients in the sample, but the bars looked exactly the same. All of these bars should be for aspirin, beta blocker, and thrombolytic therapy, should be at nearly the 100th percentile. Note one other thing. Not only are there big gaps between actual care and what it should be, the care gap, they're always bigger for older people. Remember our population demographic? It's getting older. This is something that you want to hope gets fixed before you get too much older. But remember the ladies trapped in the invisible care gap of osteoporosis? You could substitute women for the older people here too. Women compared to men, at least in cardiology, always have bigger care gaps. Not quite as much difference as older, younger, but still different from males. So you have a disease that is only in older women like osteoporosis, and you get very large care gaps. This is another one of these cultural phenomena, I believe, that we're going to have to think about and consider and start talking about and teaching about in interprofessional education going forward. The measurement issue again. There's discordant support for it too. Not everybody is willing to or believes in the value of measurement. I like nurses a lot. I always have. One of the reasons I like nurses very much is they tend to make decisions just like patients, closer in all of these surveys I've been involved in than any of the other stakeholder group, all in all, and we ask a lot of questions. But one area where nurses in voting with patients, maybe not the best thing for the future of team care and measurement is in this. Nurses line up with doctors here and the public, the patients, in their lack of support for the electronic medical record. And I'm not sure why that is. I haven't been able to find out about it. Maybe we could talk about that later. But if we're going to have an effective practical measurement system, the electronic medical record, I think, has got to be part of it. And so we have some work to do to provide the evidence to engage these other groups, including our nurses. Well, I think there's some assumptions no longer valid if we're on the edge of this next generation. One of them is that nobody's interested. When I first started to talk about this, one of my colleagues asked me if I felt like a voice in the wilderness. I think I did at one time. I don't feel that anymore. I think the room wouldn't be so full even at the end of a long day if people weren't interested. Nobody's disinterested. But current practices are not sufficient to meet the future demands. Individual care, training, and management are just not going to be adequate. And assumptions of quality are no longer good enough. We actually have to measure to ensure what we're doing and to drive us towards better things in the future. And there's definitely a need for change. Some assumptions are still valid. Demands will increase, undoubtedly, because of our aging demographic. As well, our providers are aging. Doctors are aging. Nurses are aging. Addressing costs is going to necessitate addressing the management of chronic care, chronic diseases. And quality of that care for chronic diseases is going to have to address these gaps around diagnosis, prescription, compliance with the prescriptions and access, and this age issue, or the greater gaps in the older people. There are models available. I'll tell you about one of them. You've already heard several models today from the LHIN. This is just another one to help you build this template of where to hang what you're doing. How does it fit in with other things? ICON stands for Improving Cardiovascular Outcomes in Nova Scotia. It was a large disease management project which was designed to improve the care and outcomes of patients with heart attack, unstable angina, and heart failure. So 2 acute diseases in cardiology, 1 chronic. Here's the team. This is the clinical team. There were 10 lead physicians, nurses, specialists, and pharmacists in each of the 10. These were the LHINs of Nova Scotia at the time. They're down to 9. They call them health authorities there. This was a clinical-based team of icons in each one of those small LHINs. The steering committee for this project had all of these 40 people plus Ministry of Health people from Dalhousie University, the schools of medicine, divisions of cardiology, epidemiology, and Ministry of Health, and Merck Frost was a corporate partner who funded it. Here were the team characteristics, and when you were doing the thing at 1 o'clock, I was wondering how it could evolve next year. And when you gather up all of the stories and the successes, and one opportunity that you might have for next year is to try and bring a common nomenclature to it, because how can you compare what's going on where Marlis is working with where Catherine is working without some kind of standard way to do it? So in cardiology, this is, I don't know how widely used this is, but I've been retrofitting all the projects that I've been involved with and forward-fitting the ones that we're getting into. This was published in Circulation. It's a result of recommendations of a blue ribbon panel from the American Heart Association. And we've also talked about this a lot at our group when I was in Montreal. What's a team? What's the right team for Dryden? How do you know what the right team is? How does it compare to something else? So we know so little about this. We have to start getting some collated descriptive data that allows us to compare apples with apples from Winnipeg to Thunder Bay. This is what I've fitted icons onto this. It was a polyvalent team with complementary skills. There were shared goals, including planning, shared care of the patients to some degree in the local settings, measurements of practices, outcomes, feedback was part of it. Team performance was not measured. ICON started in 1996 or 97, so it wasn't a big deal at that time. We were just doing it.